I think KEYNOTE-189 established the regimen of carboplatin pemetrexed plus pembrolizumab as a standard. One of the issues we're often faced with is can you change up the chemotherapy part of it? Could you substitute, for instance, paclitaxel or say nab-paclitaxel for the pemetrexed? Now we have other studies suggesting that you can, but in general, to date, those have not been in non-squamous, they've been in squamous. In my practice, I tend to stick with what was done in the phase 3 trial. There are occasionally a patient that you would not want to give pemetrexed to. Pemetrexed is renally excreted, so patients who have borderline kidney function are at heightened risk of side effects from pemetrexed. And so I might avoid pemetrexed in someone who had some renal insufficiency. You can substitute paclitaxel in that setting, and I don't think that you would necessarily compromise anything. We do have clinical trials, particularly in squamous cell, suggesting that adding immunotherapy to a carboplatin plus a taxane regimen does result in improved overall survival, as I previously mentioned. So it's not a very common situation where you would exclude, except in the elderly. The older you get, the less organ reserve that you have. So the renal issue does come up quite more frequently in the elderly patients than it does in more standard age patients. In the history of oncology, we know that the more drugs you use, the more side effects you're at risk for. Fortunately for the KEYNOTE-189 regimen, we do have a situation where the side effects tend to be non-overlapping. The side effects of pembrolizumab are typically the typical immune-related sorts of events. The common ones, skin rash or dermatitis, colitis with diarrhea, thyroiditis with either more commonly hypothyroidism, hepatitis with liver function tests and stuff like this. But I think it's important also to realize that as a general rule, anything that ends in itis can occur as a side effect of immunotherapy. I've said the common ones: dermatitis, colitis, hepatitis, thyroiditis, these sorts of things. But you have to be aware that there have been some weird itises that have occurred as a result of this myocarditis, aseptic meningitis, encephalitis, all uncommon uveitis, all uncommon things. The point to the general oncologist is that the spectrum of toxicity is pretty broad. Once you activate your immune system, it can attack pretty much anything in your body if it thinks it's foreign. So that's really the issue. Now, those are very different than the side effects of chemotherapy, which are more related to the bone marrow in terms of blood counts. Fatigue is a very nonspecific symptom, but commonly associated with chemotherapy. There can be some issues with the renal and GI sorts of toxicities, but the way they present is somewhat different. I think an experienced oncologist would recognize the difference between those two. Fortunately, when you put all these drugs together, relative to the benefit, and I think you always have to interpret the side effect profile relative to how great the benefit is. We talked before about the hazard ratio for overall survival showing a 50% risk reduction in death. To me, that's worth taking a little bit of risk in toxicity. Now, fortunately, I don't think personally, you take a huge leap in terms of subjecting the patient to substantially more side effects relative to the substantial benefit that they're getting from this regimen.